Good afternoon, everybody. Thank you very much for joining. So we're at 12 o'clock or just past, so we'll make a start. So thanks very much for joining. The number of registrants and people that have joined has clearly, has blown us away. So it's clearly an interesting topic for a lot of you. So as you're aware, this webinar is about falls pathways and how can we prevent the revolving door. So before we kick off into that, I just wanted to do a couple of housekeeping points. So we'll keep this webinar to roughly an hour long, and you'll see that there's no chat function on the webinar, but there is the option for a Q&A. So we really want to encourage participation the whole way through this webinar. So if you've got any questions or queries or thoughts that you want to discuss, then pop them in there, and then at the end we'll be going through those. It's often where a lot of the value and wider learning is in those questions, so don't hold back. So the number of participants and registrants is clearly quite confirming that there is definitely falls is something of interest to a lot of you, which is good because falls is something that we have a deep interest in as well. In fact, we've got a vision that we don't often talk about. We'll be doing that more so, but our vision is that we need to be moving into a position where going forward, there are no ambulance call-outs to non-injury falls. That's the journey we're on, and glad that you're joining us today as part of this webinar. So this webinar isn't about us, it's about you, and we want you to get a lot of value from this. So hopefully by the end of this session, you'll have greater understanding of the impact that falls have and the challenge that they're presenting to the NHS, and come away with some fresh ideas and energy that you can bring back to the team as to ways you can help with this problem. So we're joined today with three panelists, and I'll go through them briefly, very quickly, as to what they're going to be covering, and then you won't see anything more of me until a little bit later on. But we'll be kicking off with Dr. David Shipway, who is a consultant physician and a perioperative geriatrician. He's going to be going over falls and the effects both on people and also on the system. Then we'll be moving on to Louise Bolson from Southwest Ambulance Service. She's the falls and frailty lead. She'll be going over a lot of statistics related to falls and long lies, what they are, and then decision making. What should and could care providers be doing to help with this problem? And then finally, we'll be going to Amy Hassan, who is the head of urgent community response in Dorset, and she'll be kind of combining what Louise and David have spoken about into a bit more of a real life scenario and how a correct response differs to that of an incorrect response and what the impact will be. Then will be a real quick demonstration, and then we'll be opening up the floor for the Q&A. So without further ado, I'll hand over to Dr. David, who will take it forward.
Well, thanks very much for that introduction. I'm a geriatrician, as you have probably heard already, in Bristol, and I'm going to be talking in the next few minutes really a little bit about why these older people fall over and then why they can't get up, to give a basic overview of the physiology and to help people to understand why this occurs, and then to cover a little bit about the consequences of long life from a medical perspective, both immediate and then delayed. And hopefully through those sort of bits of the presentation, the audience will be able to get an idea as to the importance of early intervention to break the vicious cycle that can evolve. Excuse me, sorry, I'm recovering from COVID, so I may cough intermittently. So to begin with, why do people fall over at all? So this, of course, is relevant to everyone, but mainly, of course, to older people who tend to fall. And this, to begin with, begins really with basic GCSE physics. It's about gravitational forces. So let's think very briefly about the center of gravity, and broadly speaking, the effect of the Earth's gravitational field on us. So our body mass is concentrated in our torso, somewhere around the middle of our torso, and normally gravity pulls us towards the Earth, with that force being exerted through our legs when we're standing up. Now, if we tilt our body over, the Earth's gravitational force falls outside of our basic sort of gait stance. And you can see this figure here on the right, this poor lady slipping over in the ice in New York this winter. She's about to go over. And it's really important, obviously, to think a little bit about the physiology of why this happens and what steps we can take to try and prevent falls innately in our neurology, and why that breaks down. So let's think very briefly about what happens physiologically to stop ourselves falling. What's going on in this poor lady slipping on the ice? So first of all, her body is detecting unexpected movements. She's slipping. Nerve signals from her vestibular apparatus in the inner ear are firing off to the brain. There's probably visual signals from the back of the eye, and her retina also firing into the brainstem. And proprioceptive nerves in her limbs and her torso are also being stimulated right here, right now, from various different sources, all coming back up to the brainstem where they're being collected and coordinated together. So they've obviously got to travel extremely rapidly, either through the cranial nerves within the head or in the peripheral nerves in the lower limbs, the torso through to the spine. And then if they're from the lower limbs up to the spine and the brainstem itself. The brainstem then has to be able to coordinate these various signals from the various different sources and to be able to decide subconsciously what action needs to be taken on a reflex level. And that reflex might well be to put out your arm to try and stop yourself from falling or to hold on to something, or it might be some other way of increasing your stability. So, for example, changing the position of your legs or leaning one way or the other to help change that center of gravity and put it back through your lower limbs through to the earth. There's also firing of conscious signals right up to the conscious parts of our brain in the frontal and parietal lobes. That bit where we realize, crikey, I'm standing on ice, I'm falling over, what can I do about it? And then the brain will think about conscious and specific actions that it needs to take to try and maintain stability and to prevent us from falling over. And then those messages have to go back down to the right parts of the body to stop us from falling. And of course, this happens extremely quickly if you think about these processes, but they're really, really complicated. And an illustration of how complicated they are really can be gained by looking to see how long it takes us when we're born and when we're growing up to develop these skills. And you can see this toddler on the left-hand side, who's probably about 18 months, maybe 2, is learning how to walk using a walking aid. And that's because it's taken them that time to develop those coordination skills and to learn and develop those physiological abilities to stand and to retain balance. And of course, the person on the right there is at the other end of their life spectrum, where they're reaching a point where they've lost some of those abilities and now they require those walking aids. And it's hopefully clear to you all that these are really complicated neurophysiological processes. And with all complex processes, they're the first to break down when there's a crisis. So what is it that can go wrong to cause falls? Well, broadly speaking, anything that affects any part or constituent, any of the moving parts, if you will, in this process. So clearly, any disorder of the brain is going to affect the way the brain functions. So that might be delirium, it might be a stroke, it might be subdural hematoma, it might be drugs, it might be alcohol, and that can affect the higher order functions that we talked about briefly. Any damage to the spine in terms of blood supply, like a spinal stroke or a trauma, can affect the nerve signals firing up and down what is effectively a motorway, for lots of signals. Peripheral neuropathy, common in patients who are diabetic, for example, or those with nutritional deficits in older age, or those who take lots of alcohol or various other types of medication. That can affect the joint position, the proprioceptive nerves in the lower limb, so that the limbs don't really tell the brain where they are in real time and space, or they don't necessarily follow the commands sent down to them from the brain itself. And then there's the problems with bone and muscle. So if, of course, you have a poor nutritional state and you don't have muscle mass, you're not able to exert the forces that are needed to pull yourself back into line and to get that center of gravity going back through your legs again. So you can't save yourself from a fall in the way that a fit, healthy person would be able to stop themselves when they slip. And then finally, of course, any incompetence of the bones. So fractures, for example, if the reflex is to put out your arm and hold on, if your humerus is broken, you can't do that. And that, of course, is a way in which you're not going to then be able to stop yourself from falling yet again. And finally, we mustn't forget the importance of a functioning cardiorespiratory system. The brain and all these parts and constituents of the pathway need to have a blood supply for oxygen, nutrients, glucose, etc. And if that blood supply is compromised by low blood pressure, by tachyarrhythmia, bradyarrhythmia, these are aberrant heart rhythms, or low oxygen levels due to respiratory illness, that may affect the delivery of that oxygen to the brain. And that, of course, may result in a reduction in neurological function or complete loss of consciousness in the context of syncope. So there's lots that can go wrong here. And of course, as we see in older people, a lot of people suffer from medical illnesses that compromises these systems. And of course, although I've discussed now the physiology of falling and trying to retain your balance, broadly speaking, these are the similar processes that are going to be needed to get up off the floor. So if you're bad enough to go down in the first place, then getting up is often a problem as well, particularly if you've suffered from new injuries that you didn't have a moment or two before, such as these issues. So this slide here describes the surgical consequences of the fall, so the sorts of things that are very often associated with a long lie. And part of the reason for that is that if you develop these pathologies that have been shown here on imaging, it's going to be very, very difficult to get up. So on the right here, we've got a fractured neck of femur, what we call a subcapital, which is below the sort of the ball of the hip joint here. And there's a fracture there, which is going to obviously affect the ability of an individual to stand on that hip. And then on the left here, what you've got is signs of a subdural hematoma. So that's typically caused by a fall. And what you might be able to see here is that the brain on what you can see as the left-hand side, it's actually the right-hand side for the patient because the images are shown from underneath, but the left-hand side of what you can see is being squashed by that crescent of sort of grey blood underneath the skull. And clearly that squashing of the brain is going to have a significant effect on how that brain is able to function. That's probably going to be associated with a reduction in consciousness for this patient, given the size of the shift there. So clearly, if you suffer from those sorts of problems as a result of the fall, you're not going to be getting up. And that is something that's definitely going to need hospital care. However, there are other things that are going to occur if you stay down for a period of time. Okay, and these are not unavoidable after a fall. They're things that happen because people can't get up. So I think Louise is going to talk to us a little bit more about the statistics of how long people wait to be rescued after a fall or how long they may well long lie. So I'm not going to go into that too much, but broadly speaking, hypothermia. You'd be surprised. People assume that you're only going to get hypothermia if, for example, you fall over outside in the garden. That, of course, is not true. Even in an ambient sort of environment in a house, if you're on the ground for a period of time with a large part of your body's surface area in contact with a hard surface, it will draw the heat out of you and you can become hypothermic very, very quickly. In addition to that, if you're on the ground for hours, you may well become dehydrated, and this can lead to acute kidney injury. And when people start to have metabolic problems or complications of being on the ground for a period of time, they can develop hypoglycemia, even if they're not diabetic. Although, of course, a diabetic patient who's taken their insulin that morning and then can't get access to lunch may well be more likely to suffer from a hypoglycemic episode while they're on the ground. You may have heard that people who have long lies and were prone to getting pneumonia or having respiratory complications. And that's not altogether intuitive to understand why that might be the case. But this figure here at the bottom illustrates what happens to the air sacs in our lungs, the alveoli, if we're stuck in a position for a particular period of time. And you can see that this dorsal alveolus, so the patient's back here, is being compressed by the effects of gravity. The lungs are, broadly speaking, like a sponge, but it's not it's more like a wet sponge. And if you think about a wet sponge, you know that the sort of little sort of sacs within it can become compressed towards the bottom. And that's exactly what happens in the lung. And this can reduce the effective gas exchange surface for people that have already got lung pathology. So people with fibrosis of the lung or other form of lung disease can develop a worsening hypoxia just from being laid out on the ground after a fall. But it also creates a nice environment for collapse of the lung and for the development of a pneumonia, particularly if patients aspirate or they've got problems with controlling their air if they've had a reduction in consciousness immediately after a fall. So we see commonly people getting pneumonia after a fall, and that's a recognised issue, which is a real cause for concern. We also see the consequences in the skin. And again, I know this is something that Louise is going to come to later on, so I won't dwell on it too heavily, but these figures here show you in the top right a deep tissue injury as a result of a pressure, unrelieved pressure on the heel of that individual. And that deep pressure injury is likely to break down in time and cause full-scale ulceration. And if that is very deep and severe, it can even go through to bone and cause secondary bone infection like osteomyelitis. So these are things that are going to be with this patient for weeks and months as a result of suffering from this particular injury. At Southmead Hospital, where I work, we're also a regional burn centre, and we unfortunately do see people who've suffered from falls and sustained serious burns as a result of where they've been lying after that fall. This figure on the bottom right shows the buttocks of an individual that suffered from an epileptic fit and then was wedged up against a radiator for a period of time. And you can see they've suffered very nasty burns there across the buttocks, which are going to have serious ramifications for them and can become infected too. And I'm mindful of a particular case of an older individual who'd suffered a syncopal fall and landed on a wood-burning stove. So although not in direct contact with flames, suffered from serious thermal injuries to the face and torso as a result of their fall. So these are things that we do see, and they're absolutely catastrophic when they do occur. The figure here on the bottom left shows the sort of typical areas where people can develop these pressure injuries. It can be in the normal classic sort of heels, sacrum, but we also see them over the greater trochanter, over the hip, and over the internal aspect of the knee in people that have sort of lain on their side from a long lie. So they can occur in atypical and unusual places depending on position. And then I'm going to talk very quickly about soft tissue compression. So this is another consequence that we see more commonly than you would think. So if you look at this picture here on the right, this shows a cross-section of the calf of an individual, and you can see that there's sort of nice pink chunky muscle in various little compartments, which are separated by sort of tough layers of soft tissue, fascia, the sort of gristle that you see, you know, on pieces of meat. Well, it's exactly the same in the lower limb. And if you suffer from a long lie and you put aberrant pressure on one of these compartments, perhaps by an environmental obstacle, or if you've got a big bruise over one of them, or you injure the bone, for example, then it causes local sort of bruising or bleeding, what you can see is a swelling and a rise in pressure in those individual compartments. And that can, first of all, block the flow of blood, the venous drainage from that compartment, and that can result in increased pressure in that compartment, which can cause a muscle injury, and that can cause release of toxins, and that can cause more muscle damage. And we end up in this vicious cycle of damage within this particular compartment as the muscle eventually breaks down. And as the pressure rises, the blood flow gets cut off to that muscle and the muscle starts to necrose. And when that happens, the components of that muscle, the little fibers that are involved in contraction and relaxation of that muscle, end up in the bloodstream. They get filtered out by the kidney and they cause kidney failure. And that then causes all sorts of other issues, such as changes in the salt levels, the acid-base status in the blood, which then has a knock-on effect on other organs in the body, in particular the brain and the heart. And this condition is called rhabdomyolysis, and it can often arise as a result of compartment syndrome after a long lie, particularly in patients that have suffered a minor soft tissue trauma, perhaps if they've been taking an anticoagulant. So this is a common consequence, but it can be absolutely catastrophic and can necessitate emergency surgery to debride dead tissue. So what does all this mean in practical terms? Well, it means that a patient that's fallen, that perhaps hasn't damaged their head, hasn't broken a bone, but then has a long lie and develops these sorts of complications, automatically now needs medical admission. They may need rewarming, they may need electrolyte correction, they may need IV fluids, meticulous fluid balance, they may need antibiotic therapy if they've developed pneumonia. And if they continue to deteriorate, or if they've got a really nasty rhabdomyolysis, they may end up needing to go to ITU for hemofiltration while things recover. And as I've said already, they may need surgical decompression of a compartment syndrome if it is beginning to evolve in one of the problems of the lower leg. And this obviously sets off an uncontrollable train of events, which can then lead to further medical complications that are beyond the remit. But broadly speaking, almost anything goes at this point. Anything can happen. In addition to that, the nursing care that's required for these patients that have then suffered from a serious skin injury and are sick because they've got other complications like renal failure and pneumonia means they may well not be able to offset their own pressure. And that may mean that they need to have 2 hourly turns with 2-3 members of nursing staff moving them. And this is hugely intense and resource dependent for nursing staff on medical wards. And it may well require weeks and weeks of therapy, these injuries to heal. Patients often who are delirious cause further sort of problems for ward staff because of the risk of trying to get out of bed, trying to sort of ambulate without help and support, and that can be very, very time consuming for the nurses to try and manage, and it increases the risk of further falls if people don't perhaps call their call bell for help. And these sorts of patients end up in a state of functional decline, at high risk of further falls, and need complicated discharge planning. And this figure here illustrates that this is a vicious cycle that these sorts of patients fall into. So, a patient who's frail, who falls at home, maybe they fracture something, maybe they don't. But if they don't and they suffer this long lie, and they get a pressure injury and they get an acute kidney injury and delirium. That sets off an inflammatory cascade that makes them really sick and feel terribly ill. They look terrible. And then it's in our human nature, isn't it, to sort of cut them up in bed and let them do their own thing and hopefully recover, thinking that's, you know, the kind and appropriate response to that. But of course, whilst they're ill and they suffer from reduced mobility, they then become more likely to suffer from secondary and tertiary complications down the line. So if they didn't have pneumonia before and they spend a week in bed, they probably will do by the end of that week. And that then sets off this inflammatory cascade that then causes all these deliriums and other complications, including nutritional impairment, because it can affect your appetite and not want you to eat and drink properly. And that, of course, increases your vulnerability to further falls and further accidents or deterioration in physical function. And we can go round and round this cycle, and ultimately it can turn out to have long-term permanent ramifications for patients, which I shall come to in a second. There is an organic basis for this functional decline. This figure here on the left shows my brother's legs, and my brother is an emergency medicine registrar in Western Australia and had an unfortunate accident playing beach football where he ruptured his anterior cruciate ligament in his right leg. And what you can see here is after 18 weeks in an immobilization cast, his right leg has completely shriveled away, despite the fact he's been up and about walking around on crutches. And the same thing happens to older people when they're stuck in bed or relatively immobile, although perhaps not so obviously, because there isn't the clear symmetry here that you can see in this picture of my brother's legs. But we know from the physiology literature that you can lose 40% of your muscle strength if you're immobilized for 1 week. So if you have a patient that has a long lie, has got a pressure injury, needs to be turned, isn't allowed to sit out because of their pressure injury and stays in bed for a week, you can pretty much assume that they're going to be suffering from 30 to 40% of their muscle loss across all their limbs, not just one, and also their torso strength. And is it therefore any surprise that they can't get out of bed and walk the week after when the physiotherapist comes to see them? So no. And this figure here illustrates that point again. So delirium, as I've mentioned, is a state of acute confusion, and it's a marker of being medically ill. It's a brain failure that's occurring for other medical causes. And what you can see here is that even if you have a short-lived delirium lasting less than 2 weeks, it can still take you up to 4 weeks to return to your pre-hospital activities of daily living here on the y-axis. And that's up to 95% at 4 weeks. But if you have a protracted delirium, you get stuck in this vicious cycle that I'm talking about, going round and round and round the vicious cycle. What you can see here is that you plateau out. You never return to your previous baseline function, at least in that 24-week period. And you can see here that these other different lines for people who had recurrent delirium or delirium that lasted 2 weeks or delirium that never resolved, they did really badly and they had permanent functional deterioration and decline, even months after suffering from their original index event. And this is, I guess, further evidence that this is what happens permanently. And it shouldn't therefore be a surprise that these people who come into hospital that then suffer from this vicious cycle don't go home. They can't go home because they're initially medically unwell, and then they have extensive rehabilitation or care needs. And we know that access to those services is extremely limited, and our friends in social services are under considerable pressure at the moment to be able to deliver the necessary levels of care that are required for our patients once they leave hospital. As a result of those capacity problems, they don't go home. And as a result of that, there's limited flow throughout acute hospitals, and there's nowhere within the acute hospital for people to be moved out of majors, and that means that there's nowhere ultimately for ambulances to offload into majors and into resus. And this is precisely the root cause for the crisis that we're currently seeing in ambulance services up and down the country. So in summary, what we've got here is a situation in which falls are a feature of decompensated complex neurophysiology. And even if an older person sustains no immediate injuries, such as a fracture or hemorrhagic brain injury as a result of the fall, the complications of just being left in a long lie position can be extremely serious for them. I've talked a little bit about the medical complications and also those from a skin and muscle pressure injury perspective, but there's most importantly this appalling vicious cycle of functional decline that goes with a compounded sequence of medical complications. And hopefully you can now see it's absolutely essential to break this cycle as early as possible, if we have the ability to do so. I'm now going to hand over to Louise. So I'm going to stop sharing my screen and I'll be available if there's any questions afterwards.
So as Grant and Dr. Shipway said, my name's Louise Bolson and I'm the Falls and Frailty Lead for the South Western Ambulance Service. And I would like to talk about what should be happening when that unforeseeable fall happens and the importance of timely intervention. Over 25% of adults aged 65 and over fall each year. And after falling once, their chance of falling again doubles. With the number of people aged 60 or over in the UK expected to reach 20 million by 2031, falls will make up an even greater proportion of calls made to the ambulance service, placing an even greater strain on frontline resources, on hospitals due to admissions, and on health and social care. Falls are a serious threat to older people's health and well-being and are the main cause of injury-related disability and death in older people. At an individual level, falls are the #1 precipitating factor for a person losing their independence and having to go into long-term care. Prior to the COVID-19 pandemic, the 4th most common reason for requesting an ambulance related to those who had had a non-injury fall. Because non-injury falls have a lower medical need, these patients can end up spending a great deal of time waiting for an ambulance resource just to lift them from where they have fallen. This not only presents a poor patient experience, but has the potential for further harm. This image from 2020 shows the, shows the projected increase in the number of older adults experiencing at least one fall a year due to deconditioning. That's an increase of over 110,000 falls in addition to what we are already facing. The lockdowns and shielding regulations caused a loss of physical, psychological and functional capacity amongst the older population. And we are now feeling the effects of this, with calls to 999 for falls almost doubling what they were prior to 2020. The human cost of falling is threefold. It has social and psychological consequences, and these exist even when there was no physical harm caused by that fall. Patients will only pay the physical and medical prices of falling when they are left where they fell, waiting for assistance. If a non-injury fall is dealt with promptly, there ought to be no physical or medical effects. Some of the social implications following a fall include having to make changes to their daily routines and losing contact with their community, perhaps due to their inability to participate or fear of going out, and this means they become isolated. There may be financial pressures if care or equipment is needed, and all of these alongside other factors can lead to a decreased quality of life, and in the most extreme of circumstances can mean a move into or a need for further care. A fear of falling can single-handedly lead to a loss of confidence and independence, can cause anxiety, shame or anger, and fear in itself is both a consequence of, but also a risk factor for further falls, as it can result in reduced activity levels and subsequent loss of muscle mass and strength. So the term long lie is commonly used to describe anyone who's been on the floor or ground for a sustained period and has been unable to get up. But there is no set time frame which dictates a long lie. It's just one of several factors that need to be considered. Dr. Shipway alluded to a lot of these, and factors such as room temperature, the patient's hydration status, their body composition and medical history, the surface they are lying on, and their ability to move all play a part in how that long lie will affect that patient. We've discussed the physical and medical effects of a long lie, and one of which was pneumonia. And admissions for pneumonia require, on average, a 10-day stay in hospital. Sadly, around 15% of these patients will die during that admission, and for the ones discharged, 5% will die within 30 days. Another condition discussed was rhabdomyolysis, which long lies were found to be the leading cause of in a 4-year study of the condition in the elderly. Any patient who's fallen is at risk of developing pressure ulcers, pressure injuries, which can lead to pressure ulcers or sores. These cause significant pain and distress for patients and can contribute to longer stays in hospital, increasing the risk of complications such as infection. There's evidence to suggest that pressure ulcers can develop within just 1 hour, and they cost the NHS in the region of more than £1.4 million each day. All of these conditions that Dr. Shipway discussed could be avoidable if the situation is dealt with promptly. Timely intervention is vital and will reduce or even mitigate the physical and medical implications of a long lie. This graph shows the maximum waiting times for non-injury falls from 2017. As you can see, the wait times have increased dramatically due to unprecedented demand. From looking into a randomized selection of these incidents, unfortunately, a large proportion of these patients had to be taken into hospital, not because the fall itself caused any injury, but purely because of that long lie. The majority of these patients could have been assisted off the floor without the need for an ambulance response, and this action could have saved these patients from needing to be taken into hospital. Comparably, this graph shows the percentage of see and treat and see and convey for non-injury falls. Over the last year, we discharged at scene on average 79% of patients who had a non-injury fall, signifying that in a large proportion of these cases, an ambulance was not required in the first instance. Ambulance incidents that have no clinical input and only require simple lifting or moving of a patient who is not injured has a detrimental effect on our ability to achieve our goals. The majority of that 26% who were conveyed in February lived in a care facility, and they were transported to hospital purely due to that long lie. That's a huge number of patients who could have had an avoidable admission if care providers assisted that patient. The phrase "no lifting policy" is still being used, and for care providers who are CQC registered, this is unlawful and is in general unethical, and a lot of work needs to be done to ensure that care providers are in a position and are supported to provide immediate assistance to their service users after a fall. This is a statutory obligation under the Health and Safety at Work Act. So we do not want to see these numbers continue to rise or fall in this harmful way. Lying on the floor for a long time was strongly associated with serious injuries, admission to hospital, and subsequent moves into long-term care. The risk of complications associated with a long lie can be far greater than moving a patient into a more comfortable and appropriate position, even when a minor injury is noted. We want to avoid an unnecessary hospital admission at all costs, as amongst other things, it increases vulnerability to hospital-acquired infections and could cause a decline in physical ability. The National Falls Prevention Coordination Group states that managers of care and nursing homes should support their staff by ensuring that they are clear about when to call an ambulance when a resident has fallen, that they understand how to access non-emergency clinical advice and support, that they are trained to use assessments and observations to monitor for deterioration in the hours following the fall, that they have access to appropriate lifting equipment and in-date manual handling training, and 24/7 access to a computer wherever possible in order to access information and advice about what to do if a resident falls. It needs to be understood that the South Western Ambulance Service is not commissioned to provide a lifting or moving service for patients in care homes or where domiciliary care is provided. Amongst other sources, our website provides guidance which can be used by care providers when someone they care for has fallen. The post-falls guidance for care providers can be used as a training tool and reference document for anyone seeking clarification on best practice. Although this guidance provides a good basis for the majority of situations, it cannot foresee every possibility and must always be used in combination with clinical judgment, where appropriate, common sense, and in line with duty of care. When a patient experiences a fall or has been found on the ground, this tool can be used to check for any injury or new symptoms prior to moving them. There are then actions for the carer to follow, which could include calling the GP or simply observing the patient for a period of time. We do not expect those who work as health and care providers to physically lift service users, but in the case of a non-injury fall or some minor injury falls, it may be possible to facilitate a service user to self-mobilise using verbal cues. Where this is not possible, the use of appropriate manual handling techniques or manual handling equipment may be required. Leaving a non-injured person or patient with a minor injury where they have fallen for a long period of time can be devastating to their physical health and has a detrimental impact on the NHS and on community health and social care. Under the Health and Social Care Act 2008, it is understood that there are inherent risks in carrying out care and treatment, but a post-falls response will not be considered unsafe if providers can demonstrate that they have taken all reasonable steps to ensure the health and safety of the person using their services. Assisting service users, following a fall, where possible, will not only mitigate the adverse effects on the ambulance service, on our other patients and on the NHS as a whole, it will have a hugely positive impact on the patient's health and well-being. So I'll stop sharing and pass over to Amy.
My name's Amy Hassan. I am the Urgent Community Response Service Lead in Dorset. I'm an occupational therapist by background. I've worked a long time in A&E, the rehab wards, and now in the community. I'm not going to do a discussion on the community response, but a lot of the visual kind of patient journey I'm going to demonstrate is on the basis of what we could provide as a 2-hour urgent community response. But this is also about community teams, care homes, etc., about getting patients off the floor quickly and preventing those long lies, and then calling the necessary frailty teams or therapy teams within the community or GPs to do that kind of follow-up clinical assessment. So hopefully you, whatever background you're coming from, you can put it in your own context. So a bit about us. We provide a 2-hour crisis response to support patients in their own home to avoid a hospital admission. We're working directly with 111, pulling patients off what we call the CAS list, and also directly having calls from 999 to provide that first response and provide that hospital at home approach. We're a multi-professional team with paramedics, nurses, OTs and physios and assistants. It's providing that holistic kind of person, whole-centered patient care model. A lot of our patients, over half our patients, are fallers. Sometimes they're non-injury fallers, sometimes they're complex fallers. With medical issues, collapses, falls. But we link very closely with our same-day emergency care teams, community teams, our GPs, social care, voluntary sectors. So that's a little bit about the background of where I'm coming from. So as a case scenario, got a gentleman, Tom, who's fallen over, can't get up, he's non-injury fall, he's pressed his pendant alarm, has a key safe, lives alone, normally quite an independent man with his walking stick, has once-a-day care. So he's normally mobile. He has Parkinson's, heart failure. So it's quite a typical case scenario that we often find. Now, if you're going to respond in a rapid way, we're a 2-hour response, but this is about either in a care home or in a patient's home, is actually be able to get patients off the floor quickly and what the outcomes can be. So I'm just going to show you through the journey. Sorry. So the patient may ring 999 or 111, or even could go through the GP or the community teams. The Southwest ambulance could be going out, it could be our team. getting ourselves to the patient quickly within the 2-hour time frame or under. We arrive, we complete a full observation and physical examination, which then commence what we call a CGA, which is a comprehensive geriatric assessment. That's looking at the whole picture, so the environment, medication, medical issues, social issues, psychological issues. This may directly lead to need for an ED admission, so conveyance to ED, because they've either had a long lie or there's something medical that's happened. It could be a serious injury, it could be a medical collapse that's caused the need to be admitted into hospital. Hopefully, if we're undertaking that physical examination and comprehensive geriatric assessment, we'll hopefully be able to get the patient off the floor using a lifting aid. We can assess their mobility, repeat observations again, physical examinations, and that's going to lead us to the question of, are they safe at home? Which then could lead on to, actually we need to call into a frailty team within the hubs or a virtual ward, or calling into a same-day emergency care to get some advice from geriatricians or back to their GP. Do they need any additional walking aids to make them safe? We'll look at their transfers, look at their activities of daily living. Can they manage their own care needs? Can they manage their medication? Have they taken their medication? So it's that whole kind of look at kind of what's caused the fall, why have they fallen, can we keep them at home? It's that constant question of how do we keep this patient at home? How can we avoid that admission to ED? Again, any further equipment that required or medication boxes. We look at a basic need of, can they toilet? Can they basically get themselves from bed to commode, chair to commode, their basic need, in order to go, actually, yeah, we can keep this person at home. Let's see what else we need to do. Is it medication, equipment, onward referrals? Again, always having that CJ view. We might look at creating a microenvironment to keep them safe for that short period of time while we get a wraparound services through social care or intermediate care. Like I say, we have that advice and signposting. We review their care needs, and that might be a referral again into the community therapy teams, rehab teams, social care teams, voluntary sector. Obviously talking to family as well, looking at increasing their ability to support. All the way along, it's this whole comprehensive geriatric assessment, constantly looking at how we can get this person at home, providing that hospital at home approach, looking at medical treatment needed, prescribing medication like antibiotics, pain relief, what onward referrals do we need? Do they need to be booked into for an x-ray but can come home the same day? So that's what we're trying to do in order to avoid an ED conveyance and reducing the need for that patient to go into hospital and have the risk of having that long stay and that deconditioning. Everything that's been discussed already with what David and Louise have said. So this is if we get to patients quickly and then we have got there in a timely fashion. And the main thing is this person can remain in their own home. And it might be that we've had to give them additional walking aids or additional care, but ultimately they're back in their own home. However, what happens if we don't get there? Like Louise was saying, the capacity and demand in the ambulance service of reaching the category 3 calls, or care homes perhaps not having the right equipment in place or not feeling confident or competent enough to get patients off the floor, and having that worry about litigation and things like that, which comes with that as well, the education and training. So they've had to be conveyed to hospital. They would have had observations done again, possibly. They arrive in triage and have more observations and bloods and questions and the same discussions. Again, might get transferred to another part of the ED, again, repeating observations, more conversations, same questioning, tests, etc. They could be lying flat on their back for this period of time, into a hospital gown, not really knowing where they are. Have they been communicated? Already, where they're at risk of deconditioning, they're possibly going to be disorientated. There's limited access to food and drink, not because of the care, it's a busy environment. Having worked in ED, it's very easy not to be, especially with our older, frailer patient who don't necessarily always have the ability to call for help or ask, request, sometimes don't want to bother the nursing staff or doctors or therapists. They might not have access to their own medication, particularly Parkinson's meds was always a big issue. Repeated interventions, the information given to them, have they been the decision maker in this? Do they know what's going on? It's a really busy environment and not a good place for our older, frailer patients, particularly those at risk with cognitive impairment like dementia. And again, it's that deconditioning right from the beginning. They might be seen by a frailty team, which is great news. However, we might be repeating more and more things. There's also a risk, having done this comprehensive geriatric assessment, Can they do their basic need of getting home safely? Is there the capacity in the community to be able to provide that possible increase in care needs? Because already we've seen that deterioration in that patient and their frailty, and their needs are more. Are they medically stable? And if not, they're admitted to a ward. Again, observations, treatment, conversations, decision-making, and a possible long stay in hospital. With all that increases their risk of a long stay. Deconditioning. We're saying about 40% muscle wastage within 1 week, depending on their injury or their long line, their medical status. They could have hospital-acquired infections, a risk of more confusion, a risk of delirium. We're possibly increasing their care needs, which has a massive impact on social care and community therapy teams. Increasing medication needs. Can they manage those and cope with those on discharge? Is that going to have any other contraindications? The capacity and demand on, like I said, community therapy teams, back to GPs, nursing teams, social care, voluntary sector. Again, have they been informed decision-making, etc. Also, they might not actually be able to return home. Maybe their condition has deteriorated so much that they require a placement. So all these risks, and if that's not just that having a long stay in hospital, those outcomes could be just from that short period of time in hospital, in ED for that period of time, that we've already increased their care needs from a long lie, not getting to them in time, and that whole period of time of long waits possibly in ED, waiting for interventions, waiting for blood results, waiting for decision-making, transport back home, possible overnight movement and increased disorientation. So there's a huge risk of why we want to try and avoid ED conveyances for particularly our older, frailer patients who have fallen. So preventing long lies is about reducing risk to the patient, so reducing harm to that patient, reducing the risk of needing hospital or increasing care needs or injury. To risk conveyance to ED to stop the impact and the pressure for our acute trusts, as well as our ambulance services, and reducing the impact as health and social care as a system, and increasing the care needs or pharmaceutical needs or primary care needs, etc. So it all becomes part of it, why we need to prevent these long nights from happening. It's about early intervention, that's key. It's about having the right equipment in place. So things like the razor chairs is something that we have on our cars, our roaming cars, our UCR service. It's about discussions already about having them in care homes, social care, so carers having access to raising equipment, the training and education, making sure that people feel that they feel, especially, and we've already talked about in care homes, that they don't feel there's going to be a litigation issue if they're getting a patient off the floor. When can they and when can't they get a patient off the floor? Who to ring? Having far more collaborative working with their locality teams rather than putting the pressure back to the 999s. It's actually what have you got in your community through your primary care teams. Having a look at what's happening in the third sector as well. So and voluntary sector. So we've got all these full services, and it's trying to stop that kind of silo working. How can we particularly endorse it, bring together all our teams together? So we've got our urgent community response, which is a new service that we're coming to see, we're trying to go and see forward as we're not a full service, but we're seeing a lot of falls. The fire service does a lot of preventative work as well as they're also first responders as well. Could they be part of getting to patients instead of using the ambulance service? The falls responders, falls cars, particularly looking at non-injury, lower Cat 3-4 calls, linking in with dependent alarms and falls prevention programs. How can we find alternative routes and putting pressure on our acute and ambulance service and utilise what we actually currently have in the community? But the most important thing in regards to preventing long lies is about the better care for our patients. So it's providing the right, the care in the right place, by the right person at the right time. Back to you, Grant.
Thanks, Amy, and thanks all. That's absolutely excellent. Really interesting content that was shared there. So I think the resounding message across all the different topics that were covered there is that a quick response is absolutely imperative. And to enable that, there's got to be the system-wide thinking, and all the different avenues have got to be explored to enable that quick response. So my colleague Andrew, who has been hiding off camera, is just going to have a very graceful fall behind me. And I just want to, something came up in the webinar about the confidence and the competence of caregivers and anyone when responding to a fall. So I just wanted to take this opportunity to just explain really quickly how with the intervention of a simple piece of kit, such a big impact can be made. So obviously, working on the assumption that Andrew has had a non-injury fall, and to have got to that assumption, we could have used the document that Louise shared, the post-fall protocol. We'll make Andrew comfy just because we're feeling nice today. And then using the razor chair, which I should imagine a lot of you are familiar with, we'll lift Andrew up. So it comes in a couple of different packages, got a backpack and then the main seat unit. So I'll just go around this side of Mr. Webber so that we can you can see a little bit easier and hopefully hear okay. So the only movement that we're going to have to get Andrew to do is to encourage him to bend his knees, like so. Once he's done that, we'll just slide this seat unit underneath, make it roughly central, firm up against the thighs. And then in this backpack, we've got various different items. You can see that there's a clear guide as to how we put it together anyway, in case anyone was unsure. But realistically, you physically cannot put it together incorrectly. So all the parts will come out in the order in which you need them. Just encourage you to cross your arms and roll away from me very slightly. Like so. So we've got Andrew who's fallen in a very convenient location. There's plenty of space, but I totally get that when people fall in the community, maybe they're falling down next to the bed or in the bathroom or something. So the ability to use this in a confined space is absolutely imperative. So if I just get Andrew to roll towards me slightly, I can lean over, pop it in, and you can see that I can actually assemble the unit from one side. And then we've got 4 of these identical lifting arms, which we'll just pop in. Each time we're making a slight confirmation noise. Like so, and then when we put the last one in, slightly different noise. Light's gone green, which means we're safe to lift. So now we'll just support Andrew's head as he comes up. Remote control, press and hold the up arrow. Like so. So I'll just keep pressing and holding this up arrow. Obviously, if Andrew shows signs of deterioration, I can lower him back down. Or maybe as they come up, they need to kind of get their bearings. You can stop at any point, make sure they're reassured, get them a cup of tea before you then come up to the full height. So we'll keep going. And it will encourage Andrew into more of a perching position. Like so. So it's got to the top. We can just undo the seatbelt, like so, and maybe with the help of a walking frame, Andrew can then mobilise away. So I guess the point is that it doesn't have to be a complex intervention. One person can do it. I don't know that there was anybody else helping me just then. And it's a really simple way of lifting that fallen person really quickly and in a dignified and stable manner. So there's a number of questions that have come on. The first question we've got is, anybody aware of a process for implementing pendant alarms on an immediate short-term basis while a permanent one can be arranged, as these can help to avoid admission and delayed discharges? Louise, Amy?
Yeah, but some of our community teams have access to our local pendant alarm companies and can get things done quickly. But I think you're quite right. Those are the things that we need to not have delays on in order to keep those patients safe and be able to kind of avoid that admission to hospital, and they've got some safety netting around them. But I can, if I can find anything out for you, I will I'll send you my email address and I can get in contact with you.
Thanks, Amy. The next one. So, interested in CGA model. Do you have any advice on how to share information about the fall between care services?
This is probably the most issue between all of our services, between acute, hospital, ambulance service. We all have different IT systems, and sharing of previous comprehensive geriatric assessments that have been done, or frailty scores, etc. I know in the community we have access to the hospital, our local hospitals, to know what tests and things are done. We can't see all their documentation, but we can't access our ambulance services. But across our community systems, we have access to GP records, community therapy, district nursing, etc. So for our team, we're able to see most of the information, but this is repeated information. You have a CGA done by a GP, the community team, they go into hospital, they might have another one done. And also there's no set format for a CGA. It's very much what your service is providing, how, what paper, what tool they're using. So yeah, it's an issue when we don't have shared IT access. I don't know if, David, you might probably have some from a hospital point of view.
No, I'd just add to say it's an eternal problem in terms of the community interfaces, and it's a huge issue, isn't it, in terms of the integrated electronic care records from place to place. So no immediate sort of advice apart from direct sort of liaison with your local partners to see how information can best be shared. And in terms of the CGA, you're absolutely right. There's those sort of absolute defined contributory criteria. There are domains and things like that should be assessed, but it will vary from provider to provider. So how much is easily transferable and easily visible is going to vary from place to place.
That's good. Hope that helped, Rose. So, right, let's maybe start back from the top and work our way down. So, wanted to check any specific blood test for long life. Anyone up for?
I mean, I think in terms of looking for muscle damage and things like that. So whenever we see a patient in the emergency department who we think has had a long life, they should probably be having basic blood tests, like, for example, urea and electrolytes to check the kidney function, a CK, which is a creatinine kinase, which looks for this muscle damage that we can see, and gives you an indication of whether we've got an evolving situation with rhabdomyolysis. Those are going to be the key things. And then inflammatory markers to see whether they're developing an early infection. So those would be the key things, along with obviously blood sugar and the usual basic assessments. So nothing particularly controversial, fairly mainstream tests.
Okay, in which case that answer may help with this next question. So we could potentially pass through this pretty quick. So with an increased focus on admission avoidance, increased demand on South West Ambulance Service Foundation Trust and an expectation of urgent community response, what should be the clinical indicator to admit rather than managing the community? We're trying to design a protocol for long-lying community and would appreciate any agreed protocols, especially regarding bloods.
Well, I'll let David answer with regards to bloods, but unless you get someone to come into the residence to do the blood test, they need to go to hospital to have those bloods done. But the post-falls guidance that I discussed, it is a guide and it's a tool to use, but that is what we would try to promote people to use in order to know what to do with that patient. As insofar as when is it we admit a patient or convey a patient to hospital, that's all clinical decision making, and there is no set sort of criteria as such. It's a clinical decision based on that patient and the circumstances.
Yeah, from an urgent community response point of view, from the Dorset model, we kind of have two pathways. We have our locality teams that already do admission avoidance work that kind of come through either the GP or from community or 111 to look at kind of admission avoidance type work, and some of those are 2-hour responses. But we have roaming cars, which what I was talking about earlier, is a hospital at home approach. So we have all nursing equipment on board. We have therapy equipment in the car, the razor chair. We're looking at prescribing, having oxygen. We take bloods, got ECG, bladder scans, etc. So the point of our service is to provide as much possible intervention in that patient's home to reduce the need to convey and use resources within ED.
Good. Right, let's move on to the next one. I hope they help, Marie. So this one, if 74, I think this refers to a stat on your slide, Louise, if 74% of call-outs were see and treat, and potentially avoidable ambulance call-out, what were the main reasons why an ambulance was called?
I can only surmise. I don't know for sure, but I think it's to do with fear of litigation. I think care providers are frightened to move that patient themselves for fear of causing further harm. But ambulance clinicians are also under the same litigation. We can't avoid litigation if we cause an injury as well. But as I discussed, if as long as robust health and safety is put in place, and there's been a clear decision made about that patient, that there's litigation would not be an issue under the CQC regulations. But I think that's the main reason that we get called for non-injury falls, I believe.
That's really helpful, and hopefully we're on a journey to change that. So the next one, would you be able to elaborate on the no lifting policy, please?
So I'm a paramedic by background, so I'm not into the law and things like that. But the Health and Safety at Work Act and under the CQC, there's an understanding that although no lift policies are created with good intentions, they can end up having an adverse effect on the level of care that care providers are providing. And this is the opposite of what good care is. It should be delivering good care. Leaving a patient on the floor, calling an ambulance and then waiting hours and hours for an ambulance to turn up is not providing good care. So this no lift policy situation that's still occurring, as I alluded to, is quite unethical, really. It's not providing the best care for the patient, and it's having a knock-on effect to the ambulance service, to frontline resources, health and social care, etc. Ultimately, working in a care environment, you're always going to have to carry out some moving and manual handling, but as long as the risk has been assessed, the risk to the carer and the patient has been assessed, there's no reason why that person cannot be lifted in certain circumstances. It creates a better quality of life for that patient, and then reduces and saves time for that carer to then continue doing their work that they need to do.
That's good. So quality of the patient care is paramount. So next question, given the many NHS and social care initiatives currently happening around falls recovery, it would seem that there is still scope for lots more that could be done. In the community, is the issue around access to falls lifting equipment or around public awareness to how and when to lift?
I could probably help with this one. I think it's definitely about that automatic response of calling 999 in this kind of situation. So there needs to be a lot of public awareness and promotion about how we can manage and use the resources of things like 999, and when do you use 111, when do you use your locality offers in your GP practices. I think lifting equipment, most teams I know have some form of lifting equipment. It's about finding those patients that have fallen before they call 111 or 999. So our service is directly taking off 111 for exactly this reason of trying to stop that 111 call, and then an automatic call disposition to the 9s, which then they get on the cat 3 and wait until the capacity is there. And then we've already missed the boat, and we've kind of looked at that. The long lie's already happened. So I think it's initiatives about getting more access to pull off the 9s and the 1s for teams like the urgent community response and frailty teams or falls response cards. But those falls response can be from, like I've said before, the fire service, the voluntary sector, third sector, first responders. I think that's what needs to kind of happen, is looking at our current services that provide some form of falls prevention or reactive service, and kind of bring it all together.
That's really good. Thanks, Amy. Hope that helps. Brian. Debbie, what are your systems for linking with falls prevention services after ensuring the patient is safe? Reactive and proactive arm. Are we making best use of our falls service?
Possibly answered that in that last answer I gave. Hopefully that kind of links in. I think we certainly refer on to our local falls team or therapy teams to look at some rehab or reconditioning, things like that. I think there's lots of pockets of falls preventive work going on. Like I said, fire service, third sector, the work we need to do in care homes, etc. So I think each kind of service providers just need to kind of bring their systems together and make sure we've got this robust system in place rather than this silo working that's going on.
Okay, I think this next question is possibly one for oneself, and that is, how much is the Razor 2? So the one which is behind us is just shy of £3,500. That's a quick answer for you. Then we've got, and I don't know whether we may have answered this one already. What falls prevention program do you provide as an OT?
I don't provide specifically a falls prevention program. We're part of the urgent community response. We obviously look at that acute episode during a fall and after a fall and making those onward referrals. But here in Dorset, we have different localities have different access to falls prevention programs. We have a local day hospital that provides falls prevention programs, and they do home visits and things like that. We've got fire services that do health and wellbeing kind of checks. So looking at things like key safes, pendant alarms, access, etc. So I think it's all depend on different areas really. So it's looking at your locality teams really and looking what programs they already have for falls prevention.
Very good. And I believe we're on to the last question, which is on more of a statement to begin with. I'm a huge fan of the Razor and have used it lots. I was just wondering what other services use for assisting bariatric patients or those who lack trunk control up from the floor. Do you take a mobile hoist out?
Yeah, I think I completely agree. I think Razor Chair is one of our ones that we use all the time. There's plenty of them. I think when I have heard of some of the mobile hoists you can do now and put them in the car. That's something we would look at. But at the moment, we've got access to the Razor Chair for our service. Obviously, in care homes and other places, you hopefully would have access to hoist to support patients off the floor that way.
Yeah. And to be clear, the Razor Chair can lift up to 24 stone. So it would take the majority of clients that you would respond to, I would have thought. And then final question, which has just come in: what steps do you undertake to ensure everyone is aware of falls projects, as this is a key area? So I guess that's around publicity and comms. Any learning or advice from either Louise or Amy as to how you've shared the work that you're doing?
Our local CCGR commissioning group, we have a falls prevention programme itself. So it's absolutely doing exactly that, we're currently looking at where are the pockets of work going on in regards to preventative work as well as reactive work, and what do we need to do next in order to bring all the services together and know, does everybody know where to go to avoid those kind of calls to 999 and utilise a service like UCR or first responders.
Well, the next part of this statement is probably quite useful. So it says that the Razor Chair trials in London have been very successful utilising community first responders and found that chairs can be used in many other areas. So yeah, I think that's the point, isn't it, that we're trying to get to, is that there are so many different avenues in which we could approach this whole problem. But the key is making it simple and enabling as many people as possible to provide that service. So that brings us to the end of this webinar. It's been really interesting for oneself, and I'm sure for all those that have been listening. So the webinar will end shortly. There'll be a holding screen with a poll that will come up. Be glad if you could answer that, and then you're welcome to leave the webinar. Thank you very much.